Good afternoon, everyone, and welcome to this insightful webinar on drugs in biliary tract cancers and neuroendocrine tumors. I am Dr. Sandhya, coordinator of this session, and we are thrilled to have you all join us for this important discussion on two complex and challenging disease areas. I begin by introducing our program director, Dr. Safalta, who will be taking over the session and drive us through. Over to you, ma'am.
Thank you. So this is sixth series and a very good topic of biliary tract cancer drugs. So there are so many drugs. Before it was just gemcitabine, cisplatin, Folfox, immunotherapy. Now bispecific antibodies, ADCs have come up in this in the malignancies, in the group of malignancies. And we have a very learned people in the panel, so they will be teaching the students in depth, as well as they will be preparing the students for the exams. So the moderator of the session is Dr. Krupa Shankar, who is a well-known medical oncologist, director and consultant medical oncologist for NSR Can Cure Center, Coimbatore. Welcome to welcome Dr. Krupa Shankar, and hand over the proceedings to you.
Well, thank you, Dr. Safalta, for those kind words. So yeah, I think, like Dr. Safalta put it in the right way, this is a wonderful academic initiative, and so hence aptly called Gurukul, because I believe it's an absolutely wonderful way of learning and connecting with all your peers and also with renowned faculty across the group. So the focus of today's discussion obviously is going to be on biliary tract cancers and neuroendocrine tumors. And we know these are tumors or cancers that don't get discussed on a regular basis. And hence the reason for us to go ahead and discuss on these topics. And as our mentor, we have today Dr. Stalin, a good friend and colleague of mine, who's obviously mentored Dr. Teena, who's going to be presenting on all the drugs that we have. And I've also had the pleasure of knowing Dr. Teena ever since her DM days from Chennai. So without any further ado, I'll introduce Dr. Teena and hand it over to her. Dr. Teena is a consultant medical oncologist in our Medical Institute of Medical Sciences from Kollam. So looking forward to hearing from you. It's all yours, Dr. Teena. Over to you.
Good afternoon, everyone. Am I audible?
Yes, ma'am, you're audible and your screen is visible, ma'am.
Thank you. A very good afternoon to one and all. Thank you, Krupa Shankar sir, for your kind words. So today we'll be having a discussion on drugs and hepatobiliary cancers and neuroendocrine tumors. At the outset, I would like to thank the coordinators of this E-Gurukul web series for giving me this wonderful opportunity, and also extend my gratitude towards Stalin sir, Krupa Shankar sir, and Anant Ramaswamy sir for their wonderful and valuable insights, and also Sandhya madam for coordinating this session. So without much introduction, we'll be going. So first, we'll be dealing with drugs that are used in biliary tract tumors. Then you have pancreatic tumors, hepatocellular carcinomas, and neuroendocrine tumors. So some drugs which has already been covered in other sessions will be omitted to avoid repetition. So first, we'll begin with biliary tract tumors. The first drug is gemcitabine. As we all know, it is an anti-metabolite belonging to pyrimidine group of family, along with R5FU, capecitabine, and cytarabine. Chemically, it is a difluorinated deoxycytidine analog, and it is a prodrug, and it requires transportation inside the cell with the help of this nucleoside transporter system. So mechanism of action, as I told you, it is a prodrug which is activated intracellularly for its cytotoxic effect. First, it gets converted into gemcitabine diphosphate and then into gemcitabine triphosphate. This gemcitabine triphosphate is the active moiety or the active cytotoxic agent which gets incorporated into the DNA, resulting in chain termination and inhibition of DNA synthesis. It also inhibits enzymes like DNA polymerases and ribonucleotide reductase. A few words about this role of HENT and RRM1. So HENT is basically a nucleoside transporter that is present in the cell membrane. So gemcitabine, with the help of the HENT receptor, and gets entered into the cell for a cytotoxic effect. So there are certain in vitro and in vivo studies have shown that absence of this HENT receptor or decrease in the activity of this HENT receptor can lead to gemcitabine resistance. And also there is something called as RRM1, which is nothing, it is the substrate for gemcitabine, which is an enzyme, that is ribonucleoside reductase enzyme. So whenever this activity of this enzyme is upregulated, it can also lead to resistance of gemcitabine. So another mechanism of action of gemcitabine is CD44 positive cell lines have also shown to be resistant to gemcitabine. So coming to the pharmacokinetic properties, you can see interpatient as well as intrapatient variability with this drug, and it is widely distributed into the tissue, and it's also present in the ascitic fluid. So you have to be very careful in patients with ascites or liver failure. Before giving the drug, make sure you drain the ascites. It doesn't cross the blood-brain barrier, and the plasma protein binding is less than 10%. So 90% of the drug will be free. It mainly undergoes renal excretion, and the terminal half-life of the drug depends upon the rate of infusion. Normally, the standard rate of infusion of gemcitabine is you finish it off in 30 minutes. So if the infusion time is less than 70 minutes, the half-life will be around 1.6 hours. And the infusion time is prolonged, like 72 to 85 minutes, the half-life will be around 10 hours. And also there is decreased clearance in elderly population as well as in females. Coming to the toxicity profile, it can evoke allergic reaction and also bone marrow suppressions like anemia, neutropenia, and thrombocytopenia. And rare syndromes like hemolytic uremic syndromes has also been reported. Coming to its extravasation property, it is basically an irritant and it is a low emetogenic drug. And post-infusion, patient can present you with flu-like symptoms, which is seen in 19% of the patients. Coming to drug interaction of gemcitabine, you have to be very careful in patients who are receiving warfarin, which is an anticoagulant. So what we see is when you're giving gemcitabine along with warfarin, there is increase in the anticoagulant effect of warfarin, leading to increased bleeding tendency. So we have to be very carefully monitoring the INR of these patients and or decrease the dose of warfarin, or even you can change to newer oral anticoagulant that has very less interactions. So coming to supply and storage, gemcitabine is available as gemcitabine hydrochloride as 1 gram or 2 gram vials, and its properties, it's like a sterile lyophilized powder, which is stored at room temperature. And certain ready-to-use premixed bags are also available like Infugem. And pre-medication, as I told you, is like for minimally emetogenic drug, which I'll be dealing in the subsequent slide. And this gemcitabine, which is in the powder form, has to be reconstituted with the help of 20 ml of NS and diluted and given it to 50 ml of NS over 30 minutes. Cost varies depending upon the brand. It's around approximately 2,500 per 1000 mg vial. This is the anti-emetic protocol which we follow. Usually, you can give oral anti-emetic drugs, either a dexamethasone or a metoclopramide or 5-HT3 antagonist. Coming to dose modification, routine dose what we give is day 1, day 8, and day 8-15 schedule based upon your 1000 mg per meter square dose. So most of our patients may not tolerate this day 1, day 8, and day 15. So we can modify it accordingly. Sometimes we give day 1, day 15, or sometimes we give day 1, day 8 schedule. And if the ANC is more than 1000 and platelet count is more than 1 lakh, you can give 100% of the dose. And if the ANC is between 500 and 1000 and platelet count is between 50,000 to 1 lakh, you can give 25% dose reduction. And if ANC is less than 500 or platelet count is less than 50,000, better to hold the drug. So dosage in hepatic failure, you have to be careful. If the total bilirubin is more than 1.6 milligram per deciliter, you have to start considering a lower dose of around 800 milligram per meter square, especially if you're giving for your standard dose rate of infusion. There is something called as fixed dose rate of infusion, where gemcitabine is given at the rate of 10 milligram per meter square per minute. So as I told you, gemcitabine is a prodrug and it requires the help of a transporter to get inside of the cell. So if you're finishing off your infusion in 30 minutes, what happens is all these transporters will get saturated. and they will not be entering into the cell, and the active formation of the drug will not occur. So in this fixed dose rate infusion, there is a sustained release of gemcitabine through the transporter inside of the cell, and a sustained release of the active drug also occurs. In dialysis patients, you have to be careful. If the creatinine clearance is more than 30 ml per minute, then you can go ahead with your full dose. And if it is less than 30 ml per minute, you have to be very cautious because there is increased chance of myelosuppression and other toxicities. And if the patient is undergoing hemodialysis, better take up for dialysis after 6 to 12 hours of gemcitabine infusion, because byproducts can accumulate. Byproducts of this gemcitabine catabolism can accumulate, leading to prolonged toxicity. So coming to the second drug, it is nab-paclitaxel. So it is nothing, it is a conventional paclitaxel, which is solvent-free colloidal suspension, which is made by homogenizing paclitaxel with 3 to 4% albumin under high pressure to form nanoparticles. And these nanoparticles are having size of approximately 130 nanometer. And what happens is, when you're doing such things, it's increasing the pharmacokinetic properties of the drug. There will be more binding of the selective albumin-bound paclitaxel to specific albumin receptors that are present on the tumor cell, leading to increased cellular uptake and also higher serum concentration than your conventional paclitaxel. So this is your paclitaxel molecule, which is surrounded by the albumin liposome. Now, why this improved pharmacokinetic profile? It's because when you're giving nab-paclitaxel, there'll be larger volume of distribution. There'll be higher maximal concentration of the circulating free drug. And also there is increased intratumoral accumulation of the drug by this EPR effect. What is this EPR? It is enhanced permeability and retention rate. And also there is something called as albumin-specific receptor, or GP60 receptor, which helps in endothelial transcytosis of the drug. And also a word of mention about the spark protein, which is found in the tumor cell and tumor interstitium. So certain studies have shown that spark expressing cells, they perform very poor when treated with conventional paclitaxel and has decreased survival. So when you're giving nab-paclitaxel, so these are this curved structures are the spark protein. So nab-paclitaxel again attached to the spark protein, there is increased activity of this nab-paclitaxel, and certain tumors, especially breast, pancreatic, and ovarian cancer, expressing the spark protein, they have shown that when treated with nab-paclitaxel, they have improved survival rates. So coming to basic difference between nab-paclitaxel and your solvent-based or chromophore-based paclitaxel, pre-medication, since your allergen is less in nab-paclitaxel, it is unnecessary. And intravenous infusion, you can finish it off with 30 minutes for nab-paclitaxel. For your conventional paclitaxel, if you're giving a weekly schedule, infusion time is around 60 minutes. And if it's in a tri-weekly schedule, it is 180 minutes. Again, coming to dose, if you're following weekly schedule for nab-paclitaxel, it is given at the dose of 100 to 150 milligram per meter square. And weekly schedule, if for paclitaxel, as you all know, it is 80 to 100 milligram per meter square. Tri-weekly nab-paclitaxel is given at the dose of 260 milligram per meter square, and tri-weekly it is given conventional paclitaxel given at 175 mg per meter square. Now coming to properties and administration of the drug. So this comes in 100 mg vial, has lyophilized powder, and you will be provided with a separate solution, sterile solution, along with this a 20 ml solution. So basically, you have to inject this 20 ml solution through the side of the container into the vial, and you should be very careful that you do not put it directly onto the center part of the container, because it will result in profuse forming of the drug. So, and I have to gently shake it and make sure that all the visible particles, there are no visible particles, and all particles has been dissolved. And the final concentration should not be more than 5 milligram per ml, and it is put on to a infusion bag and given. And for this nab-paclitaxel, you do not require any specified like DHEP-free solution or a filter for this administration. Coming to the toxicity, myelosuppression is the dose-limiting toxicity of nab-paclitaxel also, mostly neutropenia and anemia, and very less commonly you see thrombocytopenias. Neurotoxicity is also seen as with your conventional paclitaxel, but the difference is that paclitaxel mediated neuropathy appears to me more readily reversible. Certain rare toxicities like ocular visual disturbances can be seen, and certain arrhythmias also have been precipitated. So it rarely causes hypersensitivity reactions, so pre-medication is not recommended, and it is a minimally emetogenic drug. And the dose I have already told, it's 100 to 125 milligram per meter square at day 1, day 8, day 15 of a 21 cycle, along with gemcitabine. Now, coming to the immunotherapeutic agents that we use in biliary tract tumor, first one is durvalumab. As you all know, it is a PD-L1 agent. So we all know the mechanism of escape from immune surveillance, where this PD-L1 will bind with the PD-1, leading to inactivation of the T cell activation. So if you're blocking either of these with drugs like PD-1 or PD-L1 agents, it will lead to remove of the block and activation of the T cell pathway. So durvalumab usually comes as 500 milligram vial per 10 ml, and it is diluted in 100 ml of NS and given over 30 minutes. So it's a very costly drug, but you have patient assistance programs like for 500 mg vial, it's around 1.7 lakh, and you require 1500 milligram for a single cycle. And if you buy 500 milligram, the remaining 1000 mg will be provided free of cost. So durvalumab should be withheld in case of grade 2 or grade 2 pneumonitis or grade 2 colitis, or when SGOTPT or total bilirubin is deranged. Like if OTPT is more than 3 to 5 times the upper limit of normal, or total bilirubin more than 1.5 to 3 times the upper limit of normal, and also serum creatinine level, if it is more than 1.5 to 3 times the upper limit of normal, you have to withhold the drug. And durvalumab should be permanently stopped if there is any life-threatening grade 4 toxicity, grade 3 or 4 pneumonitis, grade 3 or 4 colitis, or when OTPT levels more than 8 times the upper limit of normal, or total bilirubin more than 5 times the upper limit of normal. A few words about immune-related adverse effect. As we all know, it is the most common adverse effect that we see, and majority of these are mild. Some can be asymptomatic, some can be mild, some can be moderate. So nobody knows like who is going to develop a toxicity or the severity of the toxicity. Basically, it starts typically within 2 to 3 months of start of therapy, but can occur up to 2 years post completion of your treatment also. So risk factors, so this is a spectrum of immune-related adverse events which can be seen in endocrine system. We can see thyroiditis or hypothyroidism. You can have adrenal insufficiency. You can have hypophysitis. Lung, you have pneumonitis. Cutaneous reaction can take in the form of a maculopapular rash, pruritus, or vitiligo-like lesions. Cardiovascular system, you can have myocarditis, pericarditis, arrhythmias, even coronary artery disease. Renal, you have nephritis, and gastrointestinal toxicity, most commonly what we see is colitis and also hepatitis. So are there any risk factors for development of immune-related adverse events? As we all know, yeah, any sort of autoimmune disease can be triggered up with the use of this immunotherapeutic drugs. So baseline, if you're having any form of lipophysitis or thyroiditis, you are more prone to get immune-related adverse events. Any cardiac events like prior treatment with anthracycline, HER2, VEGF TKIs, all are risk factors for developing cardiac events. Pulmonary, same, obese patients, smoker, any form of restrictive or obstructive airway disease in the past, they are again at high risk of developing pulmonary toxicity. Again, you have certain non-specific organ, non-specific criteria like high BMI, sarcopenia with low muscle mass index, or allergies, previous allergies, high tumor burden or high disease burden when you're combining it with immunochemotherapy or vitamin deficiency and certain vaccines. Now, coming to the time of onset and toxicity of grading, most commonly what we see first to occur is your skin toxicity. It may start from approximately 3 weeks and settles in around 6 to 7 weeks. And it will be of mild form. Then you have colitis, which usually happens around 5 weeks and it can settle by around 10 weeks. Then by around 6 to 7 weeks, your endocrinopathies, basically hypothyroidism, may set in and it may last long. You may require prolonged supplementation. Then autoimmune hepatitis can also be seen at around that same time, but it will settle down in around 14 weeks. Pneumonitis usually begins around 10 to 11 weeks and settles by around 14 weeks. The last to develop is nephritis, and it can even persist more than 3 years. So coming to the management of immune-related adverse event, if you are suspecting any form of immune-related adverse event, you have to always look for any alternative cause. and you have to grade according to the CTCA criteria. If it is grade 1 mild, you can continue your immune checkpoint inhibitor with close monitoring and supportive treatment. And if it is grade 2, you can consider withholding for some time and consider corticosteroids or some form of oral corticosteroids. And if it is grade 3, you have to withhold the immunocheckpoint inhibitor and consider starting corticosteroids and slowly taper over 4 to 6 weeks. If it is not settling, you will have to go for immunosuppressive therapy if steroid refractory. Grade 4, and you should permanently discontinue immune checkpoint inhibitor and initiate corticosteroids and consider immunosuppression if steroid refractory. And you can re-challenge with the same agent once it has resolved to less than or equal to grade 1. And also, there is no option of decreasing the dose and giving or changing to an alternative immunocheckpoint inhibitor. And certain toxicities like neurotoxicity, even if it is grade 1 or 2, basically it should be permanently discontinued. Now, coming to the use of targeted therapy in biliary tract cancer, it is a target-rich disease because there are many mutations that are seen, particularly in intrahepatic tumors. You have the IDH1 mutation where you have the ivosidenib, and also FGFR fusions and rearrangement, approximately 20% of the cases where you can use your FGFR inhibitors. A few words about FGFR inhibitors. As I told, it is predominantly seen in intrahepatic cholangiocarcinoma. You have pemigatinib and futibatinib, which is already FDA approved for use in biliary tract cancer. And it is indicated only in FGFR fusions and rearrangement and not in mutation. So basically, these are the drugs that are, we have ponatinib, which is again a drug that is used in CML, which is having this anti-FGFR effect, and also edrafitinib, which is again used in bladder cancer, and you have infigratinib, futibatinib, and pemigatinib in biliary tract cancers. Coming to the toxicity of this FGFR inhibitors, class effect of this drug is hyperphosphatemia, and also you can have certain cutaneous toxicity and also particular retinal toxicity like central serous retinopathy, which is seen with this FGFR inhibitor. A few words on IDH1 inhibitor, that is ivosidenib. So basically, in this, when this IDH mutation occurs, this mutated IDH1 will produce an oncometabolite, that is 2-hydroxyglutarate, which will drive tumorigenesis. So when you're giving this IDH1 inhibitor, this oncometabolite production is discontinued and there will be restoration of the normal cellular function and reducing tumor growth. So it was approved for IDH mutant cholangiocarcinoma who has received prior 1 line of therapy. Dosage is 500 milligram once daily, and it's 70% oral availability, mainly undergo biliary metabolism. Adverse effects include fatigue, diarrhea, nausea, arthralgia, QT prolongation, and transaminitis. Now coming to drugs that are used in pancreatic malignancy, majority of the drugs has already been covered along with your GI system. Certain drugs I'll be dealing today is one S1. So as we all know, it's a fixed drug combination of 3 drugs. Basically, you have tegafouracil, which is the active drug here. It's a prodrug which gets converted to 5-FU, which is a cytotoxic agent. And you have 2 target modulators. One is gemiracil and another is otoracil. So gemiracil, what does it do? It will inhibit the enzyme DPD enzyme, resulting in decrease in the catabolism of this 5-FU, releasing and byproducts of 5-FU catabolism, thereby decreasing the neurotoxicity and prolonging the half-life of 5-FU. Otoracil is an enzyme that it's an agent that will inhibit this enzyme OPRT, specifically in the GI tract, so that the 5-FU will not get converted into the active products and cause GI toxicity. So it reduces the GI toxicity. What we see when compared with capecitabine is that S1 patients treated with S1, they have more tolerance and less incidence of side effects. So dose of S1 is usually we give in the dose of 25 milligram per meter square twice a day for 3 weeks on and 1 week off, or a higher dose schedule or a prolonged schedule is also available where you give it a higher dose like 40 to 60 mg per meter square twice a day for 4 weeks on and 2 weeks off. Now we have to be very cautious in patients who are having renal impairment. So if there is mild impairment, there is no issue. If there is moderate impairment, you have to reduce the dose. It's not recommended for less than 18 years of age, and no dose adjustment is required when patient is more than 70 years of age, and no dose modification required in patients with hepatic impairment. Two slides on liposomal irinotecan. As of now, the only indication is second-line treatment of pancreatic malignancy. It is a nanosomal liposomal preparation of irinotecan. The active product here is irinotecan, which get converted to SN38, which is the active cytotoxic agent. It's a topoisomerase 1 inhibitor, and it is used in combination with 5-fluorouracil, and also because of this liposomal preparation, the half-life is much prolonged. And it is primarily biliary excretion and metabolized by CYP3A4. Coming to side effect, diarrhea remains the dose-limiting toxicity, and also you have nausea, vomiting, myelosuppression, and mucositis. So we'll be going to the next system. We have drugs in hepatocellular carcinoma. So we have the age-old sorafenib, then came lenvatinib, then you have atezolizumab, bevacizumab, and at the first line, now we have durvalumab and tremelimumab. So second line and beyond, we have regorafenib, cabozantinib, and ramucirumab, and also you have immunotherapeutic options. So coming to tremelimumab is an anti-CTLA4 antibody. Mechanism of action, as you all know, for normal T cell activation, you require CD28 to bind with B7 for normal T cell activation. So what does happens is the CTLA4 will come and bind with this B7, leading to T cell inhibition. So if we block this CTLA4 with some form of drugs like anti-CTLA4 antibody, you can remove that block and you can activate the T cell. So indication is hepatocellular carcinoma, and now we have also indication in NSCLC. So it's always used in combination with tremelimumab at the dose of 300 milligram single dose, and then durvalumab has to be followed up. Then if the weight is less than 30 kg, you have to follow 4 mg per kg dose. So then coming to atezolizumab, it is an IgG1 anti-PD-L1 agent used at the dose of 1200 milligram for one dose, day 1 every 3 weeks. So atezolizumab should be withheld in patients with grade 2 pneumonitis, grade 2 or grade 3 colitis, any symptomatic endocrinopathies like hypophysitis, adrenal insufficiency, hypothyroidism, hyperthyroidism, or grade 3 or 4 hyperglycemias. And it should be permanently discontinued in grade 3 or 4 pneumonitis, grade 4 colitis, grade 4 hypophysitis, any grades of neurological side effects like myasthenia gravis, Guillain-Barré, or meningoencephalitis, any grade 3 or 4 ocular toxicity, any grade or of recurrent pancreatitis or a grade 4 pancreatitis, grade 3 or 4 infusion reactions, and also skin rashes of grade 4. It usually comes as 1200 milligram vial, and it is reconstituted and given in 250 ml of NS. For first infusion, you can give it around 60 minutes, and there is no infusion reaction. You can speed up your subsequent infusion and finish it off in 30 minutes. It's a very costly drug. It's around approximately 3.96 lakhs, and there is a 1+1 assistance program, and also sometimes bevacizumab will be given free of cost. Now coming to the TKIs used in HCC, you have the age-old sorafenib. It's a multi-kinase inhibitor that is inhibiting RAF, VEGF, PDA-GFR, FLT3, and c-KIT, while lenvatinib, it's more of VEGF and FGFR inhibition. Dose of sorafenib, it is 400 milligram twice daily, which is taken without food. Okay, and lenvatinib is based on weight again. If the weight is less than 60 kg, you give 8 mg, and if the weight is more than 60 kg, you give 12 mg, and it doesn't have any interaction with food, so it can be taken with or without food. Coming to the oral bioavailability, so compared to sorafenib, lenvatinib has much of approximately 98% of oral bioavailability, while sorafenib is less than 50%. And both are metabolized by CYP3A4 mechanism, so you should be very careful in using drugs with CYP3A4 inhibitors as well as inducers. Now, coming to the efficacy comparison between sorafenib and lenvatinib, there is no much overall survival benefit when you're comparing both, but there is much increase in progression-free survival, disease control rate, as well as overall response rate when you're comparing sorafenib and lenvatinib. Toxicity wise also, the incidence and severity is almost the same, but the profile is certainly different. You have, if you're using sorafenib, patient will be more of having hand, foot, skin reaction, diarrhea, etc. And if you're using lenvatinib, patients may be complaining of like hypertension, bleeding manifestations, diarrhea, hypothyroidism are those seen with lenvatinib. So if you're using sorafenib and if a patient is having hand-foot syndrome, we all know urea-based creams can be used as prophylaxis, which can decrease the incidence and severity of HFS. Now coming to drugs in neuroendocrine tumors, you have mTOR inhibitor, which is everolimus. So this will dysregulation of this PI3K AKT4 pathway is seen in neuroendocrine tumors. Specifically, you have syndromic NETs. So basically, when patients are having the syndromic neuroendocrine tumors, there is dysregulation of this PI3K AKT4 pathway, which will lead to growth, proliferation, survival, and angiogenesis. When you're using mTOR inhibitors like everolimus, you can see there is decrease in the growth, proliferation, survival, that is blockage of this downstream activation pathway. So everolimus is available as 10 milligram tablets and it's taken once daily with full glass of water. Tablet should not be chewed or crushed and it has no drug interaction with food. And the most common side effect what people complain is mucositis, and also they can have impaired glucose tolerance and dyslipidemia. Then mucositis, you can use steroid mouthwashes. Two studies have shown that like 10 ml of alcohol-free dexamethasone at 0.5 mg per 5 ml oral solution, when you are swishing it for 2 minutes and spitting it out 4 times daily for 8 weeks, reduces the incidence and severity of oral mucositis with everolimus. Now, coming to the different somatostatin receptor analogs that are used, you have different formulation. You have the conventional octreotide, which is given as subcutaneous injection, and duration is approximately 6 to 8 hours, and a dose of 150 to 300 microgram per day. Then you have octreotide LAR, which we most commonly use, which is given as IM injection every 28 days at the dose of 20 to 30 milligram. Lanreotide has two preparation. One is a sustained release IM preparation, which is given every 2 weeks at the dose of 10 to 20 milligram. And also you have a subcutaneous autogel preparation, which is given every 4 to 6 weeks at the dose of 60 to 120 milligram. What most common side effects that are seen with octreotide is injection site pain, reaction, etc. And also you can have abdominal discomfort like flatulence, diarrhea. Some even case reports of gallstones are there. And also there is steatorrhea, loss of appetite, etc. Now, coming to the other chemotherapeutic agents that are used in neuroendocrine tumors, basically neuroendocrine, high-grade neuroendocrine tumors or carcinomas, you have temozolomide regimen where capecitabine is given at the dose of 750 mg per meter square, day 1 to day 14, and temozolomide is given at the dose of 200 milligram per meter square per day in the last 5 days, and you repeat every 28 days. Then sunitinib is another one drug which has shown overall survival benefit, which is given at the dose of 50 mg, 4 weeks on and 2 weeks off. In neuroendocrine carcinomas, we again have etoposide cisplatin-based regimen, where etoposide is given at the dose of 130 milligram per meter square, day 1 to day 3, and cisplatin, you divide 40 mg per meter square, given on day 2 and day 3. And also in refractory cases, you have peptide receptor radionucleotide therapy, where you have lutetium-177 given at the dose of 200 millicurie over 30 to 40 minutes every 8 weeks for a total of 4 treatments. Thank you.
Well, thank you, Dr. Teena, for that wonderful overview. I think that was a very rapid overview as well. Did a great job of trying to consolidate everything. So pleasure listening to you. So, just a couple of things that I just wanted to touch on and highlight as well. So like Dr. Teena was highly pointing out about nab-paclitaxel or albumin-bound paclitaxel, the current terminology that we use for all of these nanoparticles is PICN, or paclitaxel injection concentrate for nanodispersion, meaning they're all not one and the same. We have polymeric preparations, lipid-bound micelles, and various formulations of these nanoparticles. So in a nutshell, they're all better drug delivery systems, which help us enable to reach the drug to reach the tumor cells in a better way and also bring about a better therapeutic effect. So that's one thing that I really wanted to highlight on as well, as far as the current terminology. Earlier, it was called PICS, which is nothing but paclitaxel injection concentrate for suspension. Now it's called nanodispersion, meaning that they're all nanoparticles. And again, as far as, I think the current trend, obviously, there's no talk that can go on complete without mentioning about immunotherapy, all thanks to Professor James Allison from the MD Anderson Cancer Center at Houston, Texas. And Tasuko Honjo from the Kyoto University of Japan, who instrumental people who were absolutely, instrumental in bringing about the CTLA4 inhibitors and PD-1 inhibitors that we keep talking about every day. And just to briefly elucidate on how the immune system actually functions, we always talk about immune surveillance, immune editing, immune tolerance, and finally immune escape. So what happens is these cancer cells are able to escape or evade immune surveillance by posing PD-1 expression on their cell surface. So what we do in a nutshell is we are trying to cut off that signaling supply by using PD-1 inhibitors. And that's how we come across these drugs. So remember, when we talk about the immune system, we have co-inhibitory checkpoints and co-stimulatory checkpoints. PD-1 and PD-L1 are classical examples of co-inhibitory checkpoints. So in a nutshell, what you're trying to do is when you block the PD-1 or the PD-L1, you're basically releasing the brakes of the immune system. You're making the immune system more active, and you're bringing about a cytotoxic T cell response, T helper 1 response, which will help you identify, seek out, and destroy the tumor cells. So remember, PD-L1 is the ligand and PD-1 is the receptor. And it's the interaction between the ligand and the receptor which helps to keep the immune system under check. And this is not just the only pathway that we know. There are so many others like the LAG3, the lymphocyte activation gene, TIM3, TIGIT, IDO pathway, indolemin deoxygenase pathway, and the VISTA pathway, and so on and so forth. They're all co-inhibitory checkpoints. So what about co-stimulatory checkpoints? Are we there as far as identifying if we can actually work on them as potential drugs for the future? Absolutely, yes. CD28 and B7H3. There are a host of drugs being looked at where we're looking at co-stimulatory checkpoints as well and looking at drugs that can act on co-stimulatory checkpoints. And is there a difference between PD-1 and PD-L1 inhibitors? Absolutely, yes. And the reason why I say that, this is a fantastic review article which is published in JAMA as well. Remember, when we talk about the ligand, we might have more than one ligand for a receptor. PD-L1 is just one of those ligands. You have something called PD-L2 as well, another ligand which can also activate the receptor, which also explains the difference, where we always thought, is there a difference as far as the toxicity is concerned with PD-L1 as opposed to PD-1 inhibitors? And PD-L1 inhibitors in general seem to be slightly better tolerated as opposed to PD-1 inhibitors. And also another key reason as to why you see only PD-1 inhibitors being approved even for hematological malignancies, because that expression is seen throughout. And, again, moving forward to neuroendocrine tumors as well, I think one key thing that you would probably want to remember is the Krennig score, which absolutely predicts for the response to PRRT. So remember, anybody with a score of more than 2, based on the Krennig score, would actually benefit with PRRT therapy. We now have the data to do that as far as GPNETs grade 2 and beyond are concerned, even in the first line, along with sandostatin LAR. So that's yet another key update that's come up. And I'm not going to take too much time again after this. So I'm going to say that, the most important key thing is not just about getting to know all these drugs, the mechanism, all of those things really do matter. You could always brush it up on your theory. But knowing about each drug, as far as whether it's in a powder formulation or a crystalline formulation, how do you actually end up mixing these drugs, preparing these drugs? And I can tell you right from our residency times, the people who we learned a lot is from our ward sisters. They would absolutely teach us everything that goes as far as mixing these drugs, preparing these drugs, the availability, the vial strength. All of these things are practical things that will actually go a long way in helping us even when we complete our residency. So with that, I'm going to introduce our expert for today. I have the pleasure of introducing Dr. Anant Ramaswamy, yet another good friend, one of the minds of GI oncology in India and one of the leading lights of GI oncology in India. So over to you, Anant.
Thanks, Krupa. I think Dr. Teena's lecture set the tone, and it'd be great if you're around and can ask questions in between with the ones that have already prepared, and so that would give a different perspective if possible.
Definitely.
So, yeah. Okay, so can we have the questions on screen, please? I think it was. So it's Dr. Adithya and Dr. Hemalatha. Both of them are here, right?
Yes, sir.
Yes, sir.
Yeah. Okay, great. So the idea is that most of these questions were prepared by Dr. Teena, and I've just made some modifications. And these questions are only the starting points. We could have questions in between which go from here as well. Okay. So,
Yes.
yeah. Next slide. Okay. So this is easy. I mean, this is just the infusion gemcitabine. Next slide. Okay. So what are the, Dr. Adithya, maybe I'll start with you. What are the available strengths for the premixed gem?
So, 1500 mg of this one, sir, premixed.
Yeah, is 500 also not available? I think 500 is also available.
Yes, sir. 500 is there, sir. Yes.
Yeah, so I think 500 is available. And what do you think the major advantage of this premixed is?
Sir, maybe this one less infusion reactions are less and less amount of infusion reactions may be less comparatively. And
Dr. Hemalatha, what is the major advantage?
It is easy to administer and faster in preparation. No need of any preparation, any dilution. It is easy made.
Basically,
ready-made.
handling issues are avoided. Handling issues when prior to administration are avoided. There is no therapeutic benefit in terms of lesser reactions or outcome. It's just that handling is easier. That's all. Okay. Next is what time, Dr. Hemalatha and Dr. Teena had referred to this. What is the usual time for infusion of gemcitabine? Let's say I'm giving 1200 milligram of gemcitabine to a patient. What is the usual infusion time?
30 minutes, sir.
Okay. Is there any benefit or lack of benefit if I give a lower dose over 6 hours? Is there any evidence for that? Are you aware of this? So I know that normally biliary tract cancers or gemcitabine was used in non-small cell lung cancers also. So is there any evidence to say that if I give it over 6 hours at a lower dose, is there some benefit, lack of benefit with that? Any idea? Dr. Adithya?
chance of toxicity is more if you given for longer durations.
Okay, so there are 2 to 3 studies which have said that because earlier there was some evidence that maybe these low dose long infusion times would increase efficacy. Okay, but that has now been largely disproven. There are similar outcomes with similar side effect profiles. So it is not taken forward. There are studies to say this. You should just be aware of it, because this was a concept a decade or so back, but it's fallen out of favor in, okay. Where are the malignancies that you use gemcitabine as a radiosensitizer? Which malignancies? Adithya?
Sir, gallbladder response can be used. 300 mg per
Biliary tract cancer would be a better answer. Whereas pancreatic cancers also, right?
Yeah.
You can use it as pancreatic cancers also. So in both HPV, in both biliary tract and pancreatic cancers, is there any other drug that you can use as a radiosensitizer?
Capecitabine can be used.
Anything else?
5FU, sir. 5FU.
Okay. Anything else? So you've given all the right answers. S1 can also be used. Okay. The Japanese use a lot of S1 as a radiosensitizer also. Okay. So Dr. Hemalatha, what is the dose of gemcitabine as a radiosensitizer? Let's say in pancreatic cancer, what is the dose of gemcitabine as a radiosensitizer?
Sir, I'm not sure. It's at 750.
Okay. When you're not sure in such a forum, you can always guess. It's okay. Right? So it's always best to give a range. The range is 300 to 800 milligram per meter square. Okay. So for example, in my institution, we use 300 milligram per meter square. In a lot of other institutions, they use 500 also, 600 milligram per meter square also. But the answer is 300 to 800. Okay. And also remember that 5FU, capecitabine, and S1 can all be used as radiosensitizers in the cancers like pancreas, HPV. Even in rectal cancers, S1, CAPE, and 5 can be used. Next slide, please. Yeah. Yeah, okay. Next slide. I think we've covered this. Next slide. Okay. The previous one, please. Yeah. So, Dr. Hemalatha,
Yes, sir.
this is the scenario given to you. A patient received gemcitabine cisplatin on 16th of February, and next day he comes with fever. What do you think your diagnosis is, and how will you proceed?
Sir, the option 3 and 4.
Okay, so 3 and 4 is what you think, correct? Okay. Dr. Adithya, what do you think?
Sir, option 4 is more probable, sir, because advanced cholangiocarcinoma, they might have cholangitis associated. There is high chance of cholangitis with that cholangiocarcinomas.
Okay, so I mean, the answer probably would be anything but 2. Okay, it's unlikely to be a drug fever due to cisplatin. All the other 3 are possible, but the most likely is option 3. Okay, it's unlikely that on day 2 of chemotherapy you will develop febrile neutropenia. It's unlikely that, unless you have a susceptibility to one of these drugs, which is very, very rare. Cholangitis 1 day after chemo, unlikely. You will start chemo in patients who have limited jaundice or no jaundice or treated cholangitis. Within 1 day, you will not have. So remember that within 24 to 48 hours post gemcitabine, a very high number of patients actually develop flu-like syndrome, including fever, and they just need to be treated with paracetamol, right? So that is the most likely cause of this fever. And the temporal profile is what is important. Yeah. Right. Next question. Okay. Dr. Adithya?
Sir, this one gemcitabine is known to cause in rare instances, so hemolytic uremic syndrome is a possibility, sir.
Yeah. Okay. Right. Dr. Hemalatha, do you think it could be anything else? So anemia, thrombocytopenia, and renal insufficiency.
Yes, sir. Even I am suspecting that only. Even though it is rare, but it is seen, sir.
So, I mean, I understand that this scenario is meant for HUS. Plus, please think of, infection, sepsis, DIC, and all that. Okay. It is just to highlight that gemcitabine can cause all this, but that would be second or third on your list. But yes, you should remember that, HUS TTP is. Dr. Krupa, you want to add anything?
No, I'm good. I'm good. Go ahead.
Okay, right. Next slide, please. Yeah. What's the pathophysiology, Dr. Adithya?
Sir, this one pathophysiology, I'm not sure, sir, HUS in gemcitabine.
Dr. Hemalatha?
Not sure, sir.
Yeah. So, next slide, please. Yeah, it's basically the same as, the infective cause it's mentioned here. Like, it commonly is infective, right? Sugar toxin in children, So it is based on that only. I don't know how much of pediatrics you or I remember, but it was the sugar toxin induced HUS as an infective cause and endothelial damage is the same thing. Okay. And the thing to remember is that transfusion and dialysis along with discontinuation are the key. Right? Those are the key things. I personally have no experience with eculizumab. I have no idea. But it is transfusions, discontinuation, and dialysis if required. And patients usually do recover. Okay, that's what we need to know. Great. Next slide, please. Okay, just before we go on to the next drug, I just want to know that let's say you have a patient of advanced biliary tract cancer with you, Okay, what are the and all the workup is done, the patient is okay. What are your standard options that you will use for chemotherapy? We'll start with Dr. Hemalatha. Yeah. A patient has come with an advanced intrahepatic cholangiocarcinoma. It is unresectable, not for radiotherapy. What is the standard chemotherapy schedule that you will consider? Dr. Hemalatha?
Sir, gemcitabine plus nab-paclitaxel or FOLFIRINOX.
In advanced cholangiocarcinoma, so gemcitabine, nab-paclitaxel or FOLFIRINOX? Okay. Dr. Adithya?
Sir, gemcitabine with cisplatin with durvalumab can be
Yeah, so the easy and straightforward answer should be gemcitabine plus platinum.
platinum.
Right? GemCis or GemOx. In India, there is data for GemOx also from AIMS. So those two, and you should consider a monoclonal, a PD-L1 inhibitor also. Gem-nab-paclitaxel is not a standard, usually not considered. FOLFIRINOX, there is actually negative data that it is not better than GemCis. So that would not be a first-line option. Okay, good. Okay, the last question on this biliary tract is, let's say you have to write a prescription including antiemetics and fluids for GemCis. Dr. Adithya, could you just quickly run through a prescription? So day one, GemCis. Yeah.
So day one, gemcitabine with cisplatin both together would be of moderate intensity of hematogenic potential, sir.
Would you want to correct yourself?
Moderate to we would require triple therapy, sir. Minimum of triple therapy, anti-emesis.
So highly emetogenic.
I mean,
Okay.
highly emetogenic. Yes, sir.
Easy answer. Okay.
Triple therapy would be advised.
So,
with
so triple therapy is not enough. Full prescription. Yeah.
Yes, with H2 receptor inhibitor, then granisetron as well as dexamethasone anti-emetogenic dose along with neurokinin inhibitor, NK1 antagonist.
Okay, so just remember for exam purposes, always specify the drug with the dose. Examiners kind of like that, right? So let's say you're giving palnositron, then it should be 0.25. If you're giving ondansetron, 8 mg. If you're giving aprepitant, it should be 125 and 80-80. Dexa should be given at 8 and olanzapine as well. Okay, so you should remember that it's highly emetogenic. All these should be given. Not to forget the fluid orders.
Yes, for cisplatin as well, hydration of at least 2 to 3 liters per meter squared of prehydration would be required, as well as KCl supplementation and along with magnesium sulfate. Magnesium supplementation would have given.
Okay, fine. Right. So we go on to nab-paclitaxel. So the main differences between nab-paclitaxel and paclitaxel, Dr. Hemalatha, could you just, in terms of administration, in terms of dosing, in terms of efficacy, can you just explain?
Sir, paclitaxel, the plain conventional paclitaxel is known for anaphylactic reaction because of the solvent, that is a chromophore, which is not there with a nab-paclitaxel because it is the albumin bound under high pressure. And here it needs the pre-medications. Here, this nab-paclitaxel doesn't need the pre-medication. And the nab-paclitaxel is like easy to administer. Here we have to use non-PVC and the smaller filters, filter IV thing, and
okay. So two things you got absolutely right: the solvent as well as the infusion reactions, and so those two are absolutely right. What about, is there any difference in efficacy across any tumor that you are aware of? Let's say that, I want to give paclitaxel and someone says, no, I want to give nab-paclitaxel in some tumor. Is there any difference in efficacy?
Efficacy wise, nab-paclitaxel is good, sir, compared to the paclitaxel.
Are you sure? Dr. Krupa, maybe you can just, is there any tumor subsite where it's proven to be superior?
Breast.
Yeah, so I don't think there's any data to say that it's superior actually. Absolutely not. I think for ease of administration, convenience, if you want to avoid a hypersensitivity reaction, or in patients who've had a hypersensitivity reaction to paclitaxel, and if you're not okay with re-challenging them, then I think we should move on to. And apart from that, probably pancreatic malignancy, it's only approved in 3 indications. One is pancreas, and then in non-small cell lung cancer as well, where it's already approved. So, and again, the other key thing that I really wanted to highlight here is that whenever we talk about albumin-bound paclitaxel, remember that whatever we are using, in practice, may not actually be one and the same. So they're all only PIC or paclitaxel injection concentrate for nano dispersion, and even when the DCJ approves it, they approve it as a biochemical entity. So they're absolutely not one and the same. They're different preparations, polymeric preparations, or missile-bound preparations, or lipid-bound missiles as well.
Yeah. So just to add on to what Dr. Krupa said, remember that some of them can only be diluted in 5% D, not MS. You have to look at each molecule. If I'm not wrong, nanoxyl or one of them, you have to dilute in dextrose and not NS. So please be careful, because there are around 7 to 8 moieties available. All of them are slightly different. Yeah. Okay.
Yeah. I'd probably just ask them, wow, why do they think it needs to be given in a codon set? Why? I mean, like to them. Why do you have to administer conventional Pacli through a codon set or a non-PBC containing infusion?
Adithya?
It is because of interaction of cremafin, sir, with
the particular term he's looking for.
What happens when you give it, through a PBC containing? What happens when you give conventional paclitaxel without a codon set or through your regular PBC set? So basically, it leaches the plastic, right? So it leaches it and it releases something called DHP, diethyl hydroxyphthalate, which is considered to be hepatotoxic. So you want to avoid that, which is why you always prefer giving it in a non-PBC containing, which could be a codeine set or a polypropylene containing set.
Remember leaching and DHP, and your examiner will be happy. Okay, both of you. That's the 2 terms you got to remember. And a lot of examiners still like to ask this question, so you should be prepared. Next slide, please. Yeah, so this I think Dr. Teena had covered very nicely during your presentation as to how you should be dealing with. Next slide, please. Next slide. Okay. So what is which are the malignancies where durvalumab is approved for use with chemo, without chemo, maintenance, non-maintenance? Dr. Adithya?
Sir, one is biliary tract cancer. Then
okay, so Adithya, when you're answering in the exam, always give in what scenario it is approved. Okay. So you say advanced with chemo.
Advanced or metastatic in gallbladder cancer as well as cholangiocarcinomas.
Okay.
Then advanced and metastatic even bladder cancer.
Yeah, go on.
The bladder cancers are advanced and metastatic, and and in hepatocellular carcinomas, unresectable advanced metastatic, we can use durvalumab with combinations with tremelimumab.
Okay. One more.
And even sir, non-small cell lung cancer, durvalumab has been used in stage 3B, where chemoradiation has been chemoradiation followed by maintenance with durvalumab.
Those are the 4 even I can think of. I'm not aware of any others. Okay, good. Okay, so if you give, now we know that this is a PD-PDL1 blocker. Is there any correlation between PDL1 expression on the tumor and whether durvalumab works or not? Dr. Hemalatha. Let's say that I have a cholangiocarcinoma, which is showing a PDL1 score of 1%, and the other patient is PDL1 of 5%. Is there any correlation as to where it will work better? Dr. Hemalatha? Okay. I am not able to hear her. Can anyone else hear Dr. Hemalatha? No, okay. Dr. Adithya, is there any correlation?
No correlation with relation to. I think there's no correlation, sir, between PD-L1 expression and use
Correct.
of.
Good. Yeah, there is no correlation in biliary tract and HCCST for sure. The other ones I'm not fully sure, but these two there is not. If I'm not wrong, NSCLC also I think as maintenance there's no correlation.
Yes,
can correct me. Okay.
So if I could just probably just add, Anant, I mean, like, what was the scoring system that they used again to him? What was the scoring? Say, we always talk about the TPS and the CPS, right? Can we talk about the TAP score that was used here? Do you know what the TAP score actually reflects, Adithya?
Sir, that I don't have an idea, sir.
Okay, so the TAP score usually refers to tumor area positivity. So whenever we talk about PD-L1 expression, remember it's a visual analog score. So earlier there was a lot of ambiguity between the tumor cell and immune cell concentration, between the cells that stain on the tumor and the cells that stain on the immune cells as well. So to take away that ambiguity is where they propose this scoring system called the TAP score, the tumor area positivity, which does not differentiate between tumor cells and immune cells. You just look at it as a whole, and then you take the raw visual analog scale and look at all the cells that take up the stain. So that was what was used in the TOPAZ trial.
What is the CPS score? Dr. Krupa mentioned CPS. Any idea what the CPS score is? Adithya?
Sir, it is a percentage of tumor cells which are stain positive divided by the total among the total number of immune cells as well as the tumor cells, sir.
Only one part of it you got wrong. Okay, so it is tumor cells expression of PD-L1 plus immune cells. Okay, of the total cells. Just remember that. The key difference is not only looking at the tumor cells PD-L1, but also at the immune cells. For example, in gastric cancers, that is what correlates with effectiveness, not only tumor. So if you get a report saying PD-L1 negative, that is not enough. You need to ask them, what is the CPS for use in some cancers? Good. Okay. So what are the common adverse event profiles that are expected with durvalumab, Adithya? Is Dr. Hemalatha here? If she's there, I could ask her as well.
Yes, sir. Yes, sir.
Okay, great. Hemalatha, what are the common adverse events that you expect with durvalumab? And tell me the common ones first. And at what time points do you expect?
Sir, it is in the form of acute and in the chronic, as well as in the system-wise, sir. It affects the endocrine system. It can cause hyper.
No. I asked you common. Tell me common first, because I'll tell you why. So, for example, you can have, inflammation of anything. What are the common ones you've seen or are normally seen?
The pleuritis.
Is it common?
No, it is not common, sir.
Okay. So think common. What in that ASCO recommendation, the first thing written is this one. I mean, if you've read it, if you've not, you should. But usually, what do you see? The first, you started off well saying acute and chronic. And acute, you rarely have infusion reactions. That's good. But what do you commonly see? Don't you see skin? Don't you see endocrine? No?
Endocrine within 6 weeks it starts, sir. The thyroid issues, hypo or hyper, or the glucose impairment.
So endocrine, we are saying under 6 months, correct?
Under 6 weeks only. It can start by 6 weeks, sir.
Little odd for them to start in 6 weeks, okay? They usually start 3 months onwards. Hypothyroid and all that, no? They usually start 3 months or beyond 3 months. Okay, the one that really starts quickly and you can see within 3 to 4 weeks is skin. Okay. We don't pay much attention to skin because most of them are grade 1, 2, they are self-limiting. But remember, the commonest is skin. What else do you see?
Sir, hepatotoxicity.
Okay. Approximately what time point?
This we have seen by the end of 2 months, sir. 2 months.
Okay. Okay, 6 to 9 weeks, you can start seeing hepatitis, colitis, those kind of things. What about lung? You had mentioned pleuritic something. When do you see that?
Interstitial lung disease by the end of 3 to 6 months, sir.
Okay, slightly more actually. And lung and nephritis are later. Skin is early, GI is in between. That's what you kind of need to remember. These are all relative numbers. A lot of us would have seen thyroid issues within 4 weeks also. But just remember that this is the time frame. That's what you need to remember. Okay. Next slide, please.
Yeah, and Anant, if I can just quickly add, this one mnemonic called champion. So C for colitis, H for hepatitis, and A for adrenal insufficiency, M for, again, myocarditis, P for pneumonitis, I for infusion reaction, O for ocular, and N for nephritis and neurological. So if you can remember that as a champion, that sort of clubs all your IRAs together. Easy way of remembering all the IRAs.
Okay, that's a useful tip. I shall take note of it when asking questions. Good. Okay. So this is the data here for biliary tract cancers, at least how the improvement in survival is marginal. It's around 1.5 to 2 months, but it's a tough cancer to treat, so it is approved. Any other immunological agent that is approved for use in advanced biliary tract cancers, Adithya? Okay. Yeah. What is the difference in the drug administrations for Pembro and Durva? Any idea?
Pembrolizumab, we are giving 200 mg every 3 weeks.
No, not the dose. That's not what I wanted to ask. Any difference? Yeah.
Pembrolizumab can be given up to 35 cycles in the keynote trial, and Durva, it is up to the disease progression, sir.
Okay. So one other important thing with Pembro is that in the study, after 6 months of chemo plus Pembro, they continued gemcitabine plus Pembro. Okay. But durvalumab was only Durva. Okay, that's an important difference, right? And yes, as Dr. Hemalatha said, the settled progression was 35. Just remember that if you have chosen Pembro, you need to continue it with gemcitabine. That's important. Yeah. Right. Next slide, please. Yeah, I think this was covered well by Dr. Teena. Next slide, please. Next slide, please. Okay. Anything you want to tell us about tremelimumab, Adithya? What other malignancies is it commonly given with Durva?
Sir, hepatocellular carcinoma and biliary tract.
Biliary tract, no.
Oh, only
hepatocellular carcinoma.
Dr. Hemalatha, any other indication?
Hepatocellular carcinoma only, sir.
No, anything other than that.
Melanoma? Melanoma, sir?
Melanoma is Nivo-EP. I don't think Durva Tremi. There's some phase 2 data in lung. Dr. Krupa, is it there?
Yeah, that's right. There is phase 2 data that we have in lung. I know, and what's more probably interesting is why, can anybody expand why it's called STRIDE, Adithya or Hemalatha? That's an acronym, it's an abbreviation, right? Why is it called STRIDE?
Sir, I know this regimen. The Tremi is the first dose which was given along with the Durva, then 4 cycles of Durva, then the assessment. If the disease is progressed, again for next dose of Tremi plus Durva, then again continuation with the Durva, sir.
No, so STRIDE actually stands for single dose of tremelimumab with regular interval dosing of durvalumab. So that's what STRIDE, actually stands for, and we call that the CTLA4 priming. So what you're basically doing is you're priming the T cells to get activated so that they present the antigen presenting cells and for your immune modulatory effect to have a better. So that's why it's, you just need a single dose of CTLA4 inhibitor. You're priming the T cells, right? And that's why it's called the CTLA4 priming. and it stands for single dose of tremelimumab with a regular interval dosing of durvalumab. That's the expansion for STRIDE regimen. So you got that right.
Good. Next slide, please. Okay, right. Dr. Adithya, this is what you have. This patient, how will you manage? Give me 5 things you will do. Simple.
The third cycle, sir, this it might be since it is a third cycle, it is almost around 9 to 10 weeks, sir. So it may be because of the immunotherapy-related colitis, sir. That can be one differential diagnosis.
Okay. What else?
Apart from that, sir, there's no if any history of fever is there, then we might suspect associated infection, but that is also infective colitis. But there's no.
Yeah, I mean, if I was given this, even I would say colitis. I can't think of a differential diagnosis actually. Probably in the early time, this one HCC patients have a lot of constipation, laxative increased use and all, but this is structured such that this is probably colitis. Okay, so what will you do? How will you treat?
Sir, we see based on the grading we have to do, sir, based on the what grade it is. Usually, if it is less than 4 stools per day, grade 1, 4 to 6 stools per day.
No, Aditya, that I know. You tell me what you will do. So when,
for example,
when the examiner asks you, and some of the older examiners specifically want treatment, okay, they will ask you if you want a grade, right? So
yes.
What will you do to manage this patient?
So initially we'll start with fluid management, sir, because of age liquid stools last this one. So
Yeah.
fluid management has to be started. Then based on the severity of based on the grading of the grading of the toxicity, usually grade 1 we give supportive management and then continue. But this is as it is 8 stools, it is grade 3, sir. So
okay,
withhold the immunotherapy, then withhold the immunotherapy, then till and give supportive management till it comes to grade 1. We can add steroids, sir, based on this one 0.5 to 1 mg per kg of prednisone steroid can be added. Then once the symptoms come back to grade 1, then we can taper slowly over 4 weeks, and then after it comes to grade 1, then we can continue our immunotherapy.
So remember that fluids, electrolyte, steroid. Okay, I mean that's the easy answer to this, right? And when as you use these immune checkpoint inhibitors, you will realize that an earlier starting of steroids on clinical suspicion is more important than waiting, because oftentimes hepatitis, colitis gets out of hand. So if you're clinically reasonably sure, start the steroids. Whether it is prednisolone or methylprednisolone, start steroids early, and then you can stop taper if you feel that it is something else, because you generally end up losing patients if you don't start steroids early. So what you said was right, good, and you covered most things. Next slide, please. Yeah, this is the same what you had said. Any drug that you have ever used when steroids have not worked, Dr. Hemalatha?
No, sir. Only the guideline I've read. The tocilizumab rule is there if immunotherapy induced side effects, but I have not used, sir.
The commoner one that is used and also available is infliximab. But the good thing with these is usually they respond to steroids beautifully. So, even I very rarely used infliximab. Okay, next slide, please. Okay, let's start with Dr. Hemalatha. So this is a ideal NET with liver metastasis who, found liver lesions on a general health checkup and no symptoms, but, he was then diagnosed with an NET. So in a suspected NET, what are the investigations you will do and how will you treat this patient, Dr. Hemalatha?
Sir, I would like to do the few of the blood investigation and imaging.
Okay, which ones?
Sir, the routine blood investigation and the
Okay, and
this PET scan, sir, DOTA TOC PET scan,
okay,
to know the SSR receptor expression. And I'll sometime, if I'm in doubt, I'll club with a FTG PET also. And
okay. Any other blood test you will do when you're suspecting anything?
Sir, 24 hours urine HIAA I can check. Then
Little plus minus, not so important. Anything else? Will you do a chromogranin? Yeah, say a chromogranin.
Yes, chromogranin.
Chromogranin A is something you should do. Okay. And I
Yes,
think again, most examiners like to hear complete hemogram, liver function, renal function. So even though it sounds boring, say it. Okay, that will
Okay.
satisfy them, right? And yes, if you suspect NET, you will do a DOTA scan. An FDG PET is controversial in low-grade NETs. You may or may not do it. Occasionally, it gives more information. And Dr. Krupa had made a point earlier on the Krennic score. That is something that you will look at on the scans. Okay, so you have done a DOTA. It is showing multiple liver mets. It is showing an ideal growth. How will you treat him? He has no symptoms, no weight loss, nothing. What will you do? Dr. Adithya, maybe? What will you do?
Sir, as this patient has grade 1 and it is well differentiated, um, but if it is only a small lesion without low bulk lesion without liver metastasis, we could have.
No, he has liver metastasis.
Yes, with liver metastasis. So we have to start with octreotide LARs, a long-acting 30 mg. This one monthly for every 4 weeks. Sir.
Okay. So just as a tip, and as you treat more NETs, you'll figure out that a lot of these patients don't need treatment. Okay. Observation is a good option, and they will do well for anywhere between 6 months to 2 years on only observation. Okay. So, which is why I said he has no symptoms, no weight loss. Okay.
So can we subject him for the surgery upfront because the tumor is low grade and
yeah. If
because
you have,
the sequence is not defined, it is like everything is practiced depending on the symptoms.
Agreed. So in a patient with a primary with resectable or treatable liver metastasis where you can remove 70 to 90% of the tumor, you can go ahead with surgery. Okay. That's the idea. You, even if you're able to remove 90% of the tumor, that is a good idea for treatment. But in case you're thinking of systemic therapy, you can wait for symptomatic or significant radiological progression. That's what I wanted to. Okay. Next slide, please. So this patient actually was observed, and after 2 years, he developed progression in the liver and some secretory symptoms also. Now, how will you treat? Dr. Hemalatha.
Sir, I will start with octreotide, sir.
Okay, right.
Octreotide long-acting 30 milligram once in 4 weeks, sir.
Okay. Okay, so from a treatment point of view, that is good. But would you want to do something else before beginning treatment? Would you think of something else, Dr. Adithya?
Scan and can plan for the PRRT therapy also, sir, simultaneously.
Okay. So one thing that you could do and is that you can do a repeat biopsy to see what the grade is now. Okay. Because over 2 years, it might have changed grade. It might have become more aggressive. And here is where, let's say, your PET scan comes into picture, gives you more information. Okay. Right. But for discussion's sake, let's say octreotide is being planned. What will you explain to the patient in terms of expectations and side effects? Dr. Hemla.
Sir, side effect profile wise, fatigue, constipation, and
common side effects.
the injection site some reaction?
So pain, actually, it's a EM injection. It can cause pain, no? So remember
Yes.
that. It does cause pain to some patients. Okay, what else?
Hyperglycemia and gallstones, we have explained.
So the easy answer is injection site, dyspepsia, long-term use, hyperglycemia, gallstones. It's usually very well tolerated. You don't have any major issues with monthly administrations. Okay, the other version we don't get lanreotide. I don't think we get in India. Okay, that's another option that is there in the West. Next slide, please. So someone mentioned PRRT, Adithya.
Yes, sir.
Let's start with the full form.
Sir,
What is PRRT?
peptide receptor radionucleotide therapy.
Okay. What are the current indications for PRRT in neuroendocrine tumors?
Sir, if patient has been started on somatostatin analogs and there has been a study, it is grade 2 or more, and uptake is there on somatostatin receptor uptake is there on DOTA scan, then can combine octreotide as well as PRT. It has shown that it has better results compared to somatostatin analogs only alone, sir.
Okay. So good, you answered, I mean, most of it. So if you had to answer in point wise, one, post progression on LAR, you can use PRRT. And in those who have a grade 2 NET more than 10% or so, it is proven better than LAR alone. Those are the two indications. So post progression and with LAR when it's a higher grade tumor. That's the okay. What are the expected side effects with PRRT, Dr. Hemlatha?
Yeah.
Any common? Any? Are you aware?
Vomiting, nausea, vomiting, sir.
Good. I think that was a guess, but good. Yeah. You
Yeah.
actually pre-medicate these patients.
Amino acid
for-
infusion are given, sir, so that might cause.
Nephrotoxicity it can cause.
Good.
That's why we will give amino acid this thing, sir.
Good. What else?
Then weakness.
Okay. I think so. Remember that there are 2-3 side effects of this. One is nausea, vomiting. One is prolonged infusions can cause myelosuppression. 2 to 3 years later, you can develop myelosuppression even when you're off PRRT, and nephrotoxicity, which is why you give amino acid infusions. Good. I mean, I think you guys covered most of it. Next slide, please.
So, Anant, probably I'll just ask one single question here.
Yeah, please.
So, somebody with the carcinoid syndrome got intractable diarrhea. Are there any drugs that are approved that you can use in those patients? Hemlatha, and then Adithya.
Sir, teletrostat is a tryptophan hydroxylase inhibitor, which is if it is resistant to somatostatin analog, that can be used, sir.
Fantastic. What dose will you use it at? Teletrostat, ethyl?
That I've not seen, sir. I'll just see.
So it's 250 milligram or 500 milligrams TDS. You can give it up. Yeah. But that's the right answer. Teletrostat, ethyl. It's a drug that can be used for intractable diarrhea secondary to carcinoid.
So your management of diarrhea would involve short-acting and loperamide, and if it does not respond, you go to teletrostat. Next slide, please. Next slide, please. Yeah, I think this is next slide. Yeah, I think that's about it from a Viva point of view. Both of you, I think, are very well read, well done. You guys just, when you're answering in the exam, just be systematic. Otherwise, I think you guys are well read. Over to you, Krupa.
Yeah, I think we had a great interactive session. Thank you very much, Anant, for those wonderful insights. Always a pleasure listening to you. I'm sure all the students would have benefited from this discussion. So, if there are any further questions, we can take those questions. If there are any queries or any doubts that anyone's got to raise, you feel free to discuss with Anant or myself. And if not, we'll hand it over back to the organizers.
Sir, we have few questions in the Q&A box.
Oh, okay.
So if you can just go through it quickly, sir, if possible.
Okay, 1 second. Let me just. Is it on the chat? Because I'm not able to see it. Is it? Or can you share it on the screen so that we can go through it? Anant and myself can go through it.
I'll share it, sir. Just a second.
Perfect. Thank you.
Sir, I am unable to share it. So I'll just read out the questions for you quickly.
Okay. All right. Yeah.
So the first question is why gemcitabine is given as day 1, day 8.
All right. So I think gemcitabine, as you've heard, even from Dr. Teena as well. So gemcitabine is a pro-drug that needs to get converted to its active metabolites. So, and hence the rationale as to why we also spoke about FDR gemcitabine, fixed dose rate gemcitabine as well. And all the trials that have looked at using gemcitabine have looked at doing it on a day 1 and 8 schedule. And that's basically because we know for any drug, we talk about the half-life and the mechanism as well. So you need the day 8 as well for the drug to reach its maximum potency. And that's how the day 1, day 8 scheduling of it's not just for gemcitabine. There are so many other drugs where we use day 1 and day 8, even for nab-paclitaxel as well, as we've discussed earlier. So I think for all of these drugs, what matters is the reason is the half-life and bioavailability, and the rationale being that it's a pro-drug that gets converted to its active metabolite, which is why we would stick to using it on a day 1 and day 8 schedule. Anant, if you would want to add, or Teena, if you're there, you want to add?
Yeah. So I was just thinking if there's any specific reason, and even I can remember only it being related to half-life. I can't think of a specific reason why, besides half-life.
Okay. So the next question is why give higher dose of nab-paclitaxel compared to conventional paclitaxel?
It's a different drug, it's a different formulation for administration. So the doses don't have to be related or even close to each other. It's this across nanodispersibles, the dose has nothing to do with the dose of the initial drug. It is based on PK/PD studies and efficacy, and from there on, the dose has come. It does not have to be anywhere close to the drugs of the original one.
Absolutely. If you look at all the bioequivalence trials that were done as well, for example, even Sun Pharma's Bevitex, the bioequivalence is what really matters. And for each formulation, it can vary, as Anant has rightly pointed out. So, you do end up using it 260 squared as well in certain studies that have been done.
Okay, sir. So the next question is where we get all chemotherapy protocols. Where do we get all chemotherapy protocols?
The BCC is a good source. The British Columbia Cancer Consortium is a good source. You can get most of the chemo protocols from there. That is the source I commonly refer to when I have a doubt. Is there any other source? I mean, there are many, I'm sure, but BCC is good. It's easily available also.
Correct. I think, I would definitely agree with that. The BCC, British Cancer Columbia Agency, and then the Vancouver as well. So all of these are, So all of these are, a good place for you to get all your chemotherapy protocols from. But then again, every institution has its own institutionalized protocols as well. So there is tend to be an inherent bias towards any of those protocols. So it's always best to look at your standard chemotherapy protocols. Like, I don't know how many of you have used that book, Edward Chu, Physician's Chemotherapy Manual. So that's another way of looking at it. Go through those books as well. So that will also tell you about the dosing and the schedule of those drugs.
Yeah, I don't know if this the Baxter. There was one small chemo book before. It was very handy. You could carry it with you and make your own modifications. That's another good source. So as Krupa said, the BCC, Baxter, and these are only used as base. You need to modify according to your institution protocol for further use.
Okay, so the next question is, can we substitute nab-paclitaxel with paclitaxel in all settings, in all malignancies?
I am thinking it's already been done. So I guess you could, even though individualized data across all tumors might not be available. But since the moiety is the same, the biological rationale is the same, I guess you could use it. I guess you could. Yeah.
Yeah, I think, I would agree. You can use it, but should you actually be using it is a different question altogether. So,
Yeah.
yeah, so because there's nothing to tell us that one is superior over the other. So it's just in terms of ease of administration, convenience to avoid a hypersensitivity reaction. All of those indications, yes, you would definitely want to switch over to, if you want to even call that a pre-medication or a steroid-free regimen, then, if you're using those drugs, then for yes, definitely look at substituting it. But otherwise, conventional paclitaxel is also here to stay.
Per se, conventional paclitaxel actually is well tolerated. Of course, there are worries on infusion reactions and all that, but if you've given it to patients, it's actually well tolerated. And yes, the lack of pre-meds and all makes a difference, but it's a well tolerated drug. You don't worry much when you give it. But yeah,
Yes, I
you
think it
can
can be
substitute, I
used,
guess.
but I think we cannot interchange the doses. The dosage of nab-pacli is different from
Oh,
paclitaxel.
yes.
Yes,
Yes,
so
you
that's
cannot
one
interchange
which
the
we should
doses.
highlight
Yes.
always.
Yes.
And the neuropathy part, always nab-pacli has more neuropathy compared to conventional.
So the major difference in the neuropathy, and there is meta-analysis for this, is that nab-pacli probably causes slightly more, but the drop-off for nab-paclitaxel is faster. That is the only difference in the clinical application of this. You probably come down to less than grade 1 in 4 weeks with nab-paclitaxel, while conventional paclitaxel will take longer, if at all it resolves. But in terms of incidence of neuropathy, it is probably same or slightly more.
Absolutely. I think, that's key. I mean, what Anant has said right now is just key because, even though the rates are higher, it's reversible.
Yeah.
So the next question is, why do we use octreotide LAR along with PRRT?
Okay. So there is a trial now for that. The NETTER-2 study actually said that if you give this, the progression-free survival, and unlike a lot of other tumors, progression-free survival is a good endpoint in neuroendocrine tumors because these patients do well for long periods of time. LAR plus PRRT is better than a higher dose of LAR alone. So that is why you use it. Using a higher dose of LAR, is it the correct comparator, is a different question. But in that study, this is what they did. That is why you combine.
Yeah. And, probably if you're talking about the rationale and the hypothesis here, Sandostatin LAR, we know, the best possible responses that you're going to get out of it is, stable disease at best. And also, it's more of for symptomatic relief, meaning if somebody's got carcinoid features of functional or secretory neuroendocrine tumors, is where, it brings about its maximum effect. And we always talk about the dosing 10, 20, and 30. Remember, even at 30 milligrams, it's at best where you get the cytotoxic effect. At 10 milligrams and 20 milligrams, you're just not going to get that effect. It's only going to be control of your symptoms, as in your flushing, tachycardia, your diarrhea. All of those symptoms are only going to get corrected. And if you the NETTER-2 looked at 60 milligrams of LAR, Sandostatin LAR. And again, the rationale as to why you want to combine it with PRRT is that you want responses. And it's only in that specific, in the first line, it's only in that specific subset with grade 2 disease of Ki67 more than 10% with GEP and ETs. And that's because you want a tumor responses. Let's say, for example, somebody's got a large volume of disease. And if somebody's symptomatic for the disease per se, I mean, like not just as far as the functional aspects of it or not just from the carcinoid features, but if you want to tumor shrinkage as well, it does help with that. So hence the rationale for you to combine a PRRT with Sandostatin LAR. You're controlling not just the symptoms, but also talking about improving on the response rates.
Yeah, just to remember that most cancers require early aggressive treatment is the thought process. NET is probably not one of them. Most of the time you can go slow, except for the situations where Dr. Krupa had mentioned, where you feel that the burden of disease is high, you need a downstaging in terms of response. Their combination is a good idea.
So the next question here is the role of everolimus in neuroendocrine carcinoma and when to add chemotherapy.
Okay, so I think the Radiant, there's this whole set of trials, I think, where they looked at everolimus. The key thing to remember with everolimus is one, it is not an initial mechanism of treatment. It is post initial therapy or post 2 lines of therapy where everolimus kinda is indicated. Two, like let's say you have given LAR, and now in the current scenario, post LAR and post PRRT in low grade NETs, it is a good option. That is one. The similar spot is occupied by chemo, and by chemo I mean capecitabine, temozolomide in low grade NETs. If post PRRT, post LAR, maybe CAP and TEM is a good option to use. The other chemotherapeutic regimen that is commonly used is cis and etoposide is essentially in grade 3 tumors or neuroendocrine carcinomas. There is data for FOLFOX also in grade 2 NETs, but these are all later options. Post less aggressive options is when you would consider chemo. I hope that answers the question.
Absolutely. And probably just to add, I think we talk about pancreatic versus extra pancreatic neuroendocrine. And pancreatic NETs is where all these TKIs came up. Again, it's not just restricted to everolimus alone. Sunitinib is also another option. Now we have cabozantinib based on the cabinet, based on the cabinet study, and lenvatinib and axitinib also have data. So the one way of looking at where you want to place this is, as Dr. Anant has rightly pointed out, in the second line or beyond 2 lines of therapy. However, if you have somebody who doesn't have much of a PRRT expression, like I said, the Krennic score, if the score is less than 2 or if it's 1 or less than 2, then you would want to look at probably using these TKIs in the earlier lines of setting. And again, as far as CAPE-TEM is concerned, you could even look at combining it with PRRT, the so-called sandwich therapy, where we look at doing PRRT with CAPE-TEM as well. So that's another option. And other chemotherapy, meaning platinum-based doublets, is where you would look at using a platinum-based doublet for Ki-67 more than 55%, or grade 3 neuroendocrine carcinomas. In general, is where we look at placing our chemotherapy.
Okay, so there is a clinical scenario which has been posted. 52-year-old gentleman post Whipple's for neuroendocrine tumor. The final histopathology report shows a unifocal 2.5 into 1.5 centimeter head of pancreas well-differentiated neuroendocrine tumor, which is grade 3. And the Ki-67 is 50% with mitotic rate of 5 to 10 per high power field with the LVI positive and a PNI negative, extending into the peripancreatic soft tissue and margins are free. The pathological nodal status is one node of the 24 nodes is positive with the extranodal extension. So what would be the further plan?
I saw this exact scenario somewhere else. I think, was it? I don't know why I feel I've seen this exact thing. Anyways, Dr. Krupa, your thoughts, and then maybe how would you treat?
So I think, NET grade 3 completely resected R0 resection, I wouldn't want to go ahead and give any adjuvant therapy here. I would just put the patient on observation, absolutely, and follow them up with regular intervals and with imaging. I wouldn't be contemplating adjuvant therapy here, Anant.
Okay. So I would have actually given chemo because there's a 30 to 40% recurrence rate and it's grade 3, but the evidence is not strong. I agree with you that the answer to that question is that based on current available evidence, is there any evidence to give chemo? No, there is not. There is an ongoing trial, I think, with adjuvant CAP and temozolomide, but that is a trial. What people do is extrapolate from the lung scenario where NECs, you give chemo and they might give cis-topo, but on paper, the correct answer is observation. I hope that answers the question.
Okay, so the next question is comparing the paclitaxel versus albumin bound weekly versus 3 weekly. Which schedule has more neuropathy? Any advantage of weekly schedule?
Oh, weekly nab-pacli versus 3 weekly nab-pacli, is that the question?
So it is put up as compared to both conventional and the albumin bound, both schedules of weekly and 3 weekly. So for both. So coming to scheduling, if now conventional weekly has does that have any advantage over the 3 weekly schedule, and is there any weekly schedule for albumin bound?
Yeah, there is weekly schedules for albumin bound, 3 weeks on, 1 week off. But in terms of neuropathy and outcomes, I'm not aware. I think it would be similar, but I don't know.
So in terms of conventional paclitaxel, or the conventional teaching has always been that weekly paclitaxel, more of neuropathy, lesser myelosuppression. Whereas 3 weekly, myelosuppression tends to be higher. So that's one way of looking at it as far as conventional paclitaxel is concerned. And this question of weekly versus 3 weekly NAP paclitaxel does not arise, because if you're going to use NAP paclitaxel, it has to be used only as a weekly. We don't try and use it as once in 3 weeks.
No, there are 3 weekly schedules, Krupa. I think there's a 200 to 263 weekly, but I don't think a differential effect on neuropathy we are aware of. I don't know. Yeah.
Correct. That's right.
Yeah.
So, whether you use 3 weekly or, especially as far as the NAP paclitaxel, if you're going with the original Abraxane is concerned, which probably is no longer available. So, I think in terms of weekly versus 3 weekly, absolutely no difference as far as using it weekly or 3 weekly. Conventional paclitaxel, yes. Like I said earlier, weekly paclitaxel, neuropathy rates are higher, but lesser myelosuppression. 3 weekly, just the opposite, lesser neuropathy with more of myelosuppression. So that's probably the take home.
Okay, so the next question here is, in case of neuropathy, do we change from conventional paclitaxel to pacli-aqualib or nab-pacli?
That does not make sense actually, because you will have neuropathy with this also. The only reason to change is probably if you have a hypersensitivity reaction. That is probably the strongest indication to change, not for neuropathy. Dr. Krupa, thank you.
Yeah, correct. I think, we're talking about trade names here, brand names. Yeah. The ideal thing is NDLS, nanosomal docetaxel lipid suspension, NDLS. So that's what it is. And again, absolutely no difference as far as the toxicities or, as far as the neuropathy being better. Absolutely, that's even if that's being purported by anyone, I think that's a false claim. So don't do that.
So the next question is, why not only PRRT?
In which line of therapy are we talking about?
No, nothing else has been answered. Only why not PRRT? Okay. So why not PRRT alone? Maybe that's the question.
Yeah, so PRRT alone, yeah, definitely. If you ended up using your sandostatin LAR in the first line, and if you want to use it, absolutely yes, it's a valid option. PRRT alone is also a valid option. But given that there is always an option of doing sandwich therapy, like we spoke about earlier. If the patient, or it all boils down to the disease status, the volume of burden, the rapidity of response. It boils down to whether you would want to combine it or just do single agent PRRT alone. Anant, your thoughts?
Yeah, PRRT in approved terminology now is when LAR has stopped working or in higher grade of grade 2 NEs. Okay, this is not a tumor where you need to go all glands blazing. So you can reserve PRRT, and don't forget PRRT also has a cost. The most conservative cost estimates for even a single session of PRRT is 2 to 2.5 lakhs. I mean, and you can correct me if I'm wrong. At least 2 lakhs. So compared to a monthly injection of LAR or something, when LAR is a good option, you should keep PRRT slightly later, unless, as Krupa had said, you want to use sandwich, you want that kind of downstaging because the disease burden is more. Those are the indications for PRRT alone in the current era.
So the next question is, what is the difference between pacli-aqualib and nab-paclitaxel?
Refer to Dr. Kripa's earlier answers.
So we have finished the question and answer section, sir. So thank you, sir, for being here and leading us to an engaging and informative session. Biliary tract cancers and neuroendocrine tumors are increasingly recognized malignancies with significant therapeutic advances in recent years. And we are really honored to have distinguished experts in the field like Dr. Anant Ramaswamy and Dr. Krupa Shankar. The insights and practical experience has deepened our understanding on treatment landscape. So thank you very much, sir. And a very heartfelt thank you to our presenter, Dr. Teena Rajan, for the time and effort she has put on this presentation. And I would also like to thank Dr. Stalin Chowdary, our esteemed mentor, for the mentorship. We truly appreciate your time, knowledge, and guidance, sir. So let us join again next week for yet another topic. on genitourinary malignancies. Thank you everybody for joining, and thank you for your time.